So when you make the stitch, always pay attention to the direction of the suture tear. The suture tear always point to the reversed direction. At the first and the second stitch. The first and the second knot. Then you can make a square knot. Now the second half. Now it's the last quarter. Now the intracranial stoma was finished. You can release the distal temporal clip at first, then the proximal. Add the last stitch. So here. Now it's quite patent. Now this is a ECA. So the ECA vessel wall was quite thick. Here's the same sequence. First it's the toe, then second here. The third stage at the 3 o'clock, then the 9 o'clock. Now, after finish the stoma, remove the temporal clip from the radial artery, then the distal part of the ICA, then the proximal part of the ICA, then again the radial artery. Now you can see the ICG, the vessel was very patent. Because this is a high flow bypass, I occluded the ICA immediately. So this is just after the bypass, we performed the angiogram immediately. You can see the blood flow supplied the whole hemisphere. So this is a STA to MCA bypass. This is a very small incision. The length of the incision is only 4 centimeters. So you can see I already, now I'm dissecting the STA. This is a cut down technique. So the bone flap was the diameter of the bone flap is only 1.5 centimeter. This is a very small bone window. So this is a STA. Methylene blue. And you can see the bone flap was very small. The recipient artery is also quite small. And it's quite pale because the pressure in the recipient artery was very low. Then cut the one oval piece of the vessel wall. This is a 10-0 threading suture. The first stage is to the toe. third stitch is the 3 o'clock point. Then the 9 o'clock. So when you pull in the suture, use your left hand, the right hand, the needle holder play as a break of the suture. you can see the very small bone window, and you can see the blood STA was quite patent, and this is a blood flow reflux to M2 segment. So this is a very fast demonstration of loop technique. Here, temporal clip the recipient artery and cut off oval piece, and then you made the loop technique. One loop can make 2 stitches. So one side, 5 loop can make 4 loops can make 5 stitches. So this is an even faster technique. So the bypass technique is not a dying art. Ischemic brain can be revascularized very successfully. So the simplest bypass technique is easy to learn by residents. Okay, thank you.
Thank you very much, Professor Shubin, for this wonderful lecture. You were able to summarize your skills and techniques in this presentation. I think, Sachin, should we have a discussion right now or move on with your presentation and leave discussion?
I think we can finish the presentation since the topic goes hand in hand, and then we can have a more interactive interaction towards the end. What do you think?
Okay. So you want to move on with your presentation first?
Yeah.
Okay, sure. Well, of course, I would like to ask my co-chair, Mirna Sobana. Is Mirna here?
Yes, here. I'm here.
To help me presenting and introducing Dr. Sachin. So, yeah, we can move on with his presentation.
Okay. I didn't have your CV, but here's Dr. Sachin Shemat. He is from India. He was the coordinator of the Young ACNS meeting monthly in this event. He worked hard for his every month meeting, ACNS Young Neurosurgeon meeting here. I hope many residents and then many young neurosurgeons can join us here. Thank you for Professor Kato and also Dr. Sneha Chitra. Dr. Sachin, I'm so sorry I don't have your CV because you're...
No problem. Thank you very much for the small introduction.
Dr. Sachin does not need presentation in this forum because he is one of the main people, right, in the ACNS Young Neurosurgeon Committee. So
he's the co-chair of the ACNS Young Neurosurgeon Committee and a member of WFNS Young Neurosurgeon Forum, also the vice president of Asian Medical Student and Resident Society of Neurosurgery. And he will present, his presentation will be the adult and pediatric moya-moya disease. I believe you are already have a lot of cases of this moya-moya disease in pediatric and adult. I hope the residents here and the young neurosurgeon in Asia can hear a lot from you. Dr. Sachin, please, time is yours.
Yeah. Thank you very much, Dr. Mirna and Professor Alberto for that short introduction. I thank you a lot. So, first of all, I'm a little bit scared. I feel like it's my exam today, as I said earlier, to talk about moya-moya disease in front of the giant of neurosurgery who's worked on moya-moya so hard, and he's got a phenomenal number of publications and research work on moya-moya, and one of the highest number of, probably the world record holder of the highest number of the moya-moya bypass surgery. So definitely it's a very tough job for me today to present Moya Moya in front of him. But as he's already, even the theme of our ACNS meeting, that we have to sort of a bridge between the stalwarts of neurosurgery and young neurosurgeon, and so that we can learn from them. So he's actually presented the technical and the surgical aspect behind it, about the tips and tricks of how you do anastomosis. But I'm going to do a little bit of maybe a theoretical and maybe orient my presentation for the young neurosurgeon to understand the Moya Moya more, maybe more in detail, and about the pathophysiology, diagnosis, and the different techniques of anastomosis. Actually, there are various anastomosis, direct and indirect, and the very weird names are there. So I'll try to make it more simpler to make you understand. So I think that I should do a justice to my job. So to start with definition, first of all, what we should know is Moya Moya, there is no atherosclerosis. That is the basic thing. So it is, first of all, a non-atherosclerotic progressive steno-occlusive arteriopathy that most commonly affects the intracranial internal carotid artery and the proximal segment of middle cerebral and anterior cerebral artery. Now, it may sometimes rarely affect the posterior circulation also. What happens is, whenever there is occlusion of any segment of the ICA, MC, or ACA, because of the occlusion, there is ischemia. And because of the ischemia, there is a formation of the collaterals. And this collaterals is what is called Moya Moya vessels. And because of these collaterals only, the Moya Moya has got its name. It was Professor Suzuki and Taka who probably saw the first image of CT angiography of the Moya Moya, and all these vessels, it appeared like puff of smoke, and then he was the one, they were the first to coin it as a Moya Moya disease. About the terminology, there are two things about Moya Moya syndrome and Moya Moya disease. What is the difference? Very, very clear. Whenever Moya Moya is unilateral and whenever it is associated with some condition like neurofibromatosis or Down syndrome, the various conditions affected, I'll tell about that later. Then in that case, it is called as Moya Moya syndrome. Otherwise, it is called as Moya Moya disease whenever it is a bilateral or whenever it is idiopathic. But the treatment goes the same. About the epidemiology, this is the recent epidemiological chart of distribution of the Moya Moya disease worldwide, given by Shang and Zhao in Neurosurgery Review. So as you can see, the red one is the highest number of cases, and that belongs to the Japan. The highest incidence, that is 0.35 per lakh. Behind every 3 lakh individuals, there is one Moya Moya. So that is definitely a high incidence. But in the Western countries, the incidence is just 1/10 of Japan. So about the sex, it is more common in the female, and it has a particular bimodal age distribution, that is larger peak in the first decade and the smaller peak around 30 to 50 years of age. Around 10 to 15% have a familial form. So what is the etiology? So earlier it was thought that it is a genetic etiology, until there were few cases like this in 1963, when there were two twins. You can see the one in the red, the one in the black is sitting quiet, but this one is carrying his hand, and he had a stroke. That's why this case report was reported in 1983 in the Journal of Neurosurgery. It says Moya Moya syndrome in only one of the two identical twins. And then there was a debate whether is it really a genetic or it's some multifactorial with some additional factors like maybe environmental stimuli. Later on, there is a lot of genetic work has happened that there are abnormalities in the chromosome 3, 6, 8, and 17, but unfortunately that has not added any change to the treatment of the Moya Moya. There are various conditions associated, like immunogenic condition like Graves' disease, thyrotoxicosis, infection disease like leptospirosis, tuberculosis, lot of hematological disorders which actually cause hyperhemoglobinemia and further occlusion of the vessels. Lot of congenital syndromes like rhinosinusostosis, Marfan's, Downs, and tuberculosis and the tuberous sclerosis. Some vascular diseases are associated like coarctation of aorta, systemic hypertension, fibromuscular dysplasia, and a lot of other conditions where we call it a secondary Moya Moya in case of head injury or post-radiation. About the pathogenesis, it's very simple. First of all, there is no atherosclerosis. Then what is the pathogenesis of Moya Moya? So one thing is there is no inflammation and there is no atherosclerosis. there are two things mainly happening in the moya moya. What is that? That there is two there. Sorry, I'll just go back and come in so that the image becomes clear. Yeah. So there are two things happening. One at the level of tunica media and one at the level of tunica intima. So in tunica media, this is the normal vessel and this is the stenotic. The tunica media, the muscular layer, there is a hyperplasia. That is one thing. And second thing is there is a fibrocellular thickening of tunica intima. Because of that, sometimes this tunica intima gives up and there is a disruption of the internal elastic lamina. And slowly over the period of time, there is a attenuation or occlusion of the internal movement. So that is what the basic pathogenesis. As long as the site is concerned, as I said, most commonly it involves the supraclinoid ICA or ACA and MCA. Rarely it involves the posterior cerebral artery and the basilar artery. Very rarely there are some case reports when it says that it also involves the extracranial involvement like superior temporal artery. And in that case, the anastomosis is a challenge. There are few reported chemicals like peptides, enzyme, and receptors have been proposed, but actually not very clear is whether are they the initial causative factors or they come because of the cerebral ischemia. But what we know is in case of moya moya disease, they are found to be little raised. Other thing is, a lot of times this moya moya is associated with saccular aneurysm. They can be either inside the moya moya vessel or they can be distant from the moya moya vessel, and they are the main cause of the hemorrhage. So 60% of the time they are in the circle of Willis and mainly affecting the vertebrovascular territory. 20% of time they are in the peripheral arteries like posterior or anterior choroidal artery, and 20% of the time they are inside the abnormal moya moya vasculature. Now that is the second part of my talk, like what is the difference when it comes to a pediatric and adult moya moya disease, whether do they present similarly or differently. So there is definitely a difference. As long as the pediatric moya moya is concerned, most common presentation is stroke or TIE. Almost 70 to 80% of the moya moya in pediatric will present with a stroke. And overall pediatric strokes, 6% of the time, the moya moya is the cause. In fact, there is a very well-known statement that the child with the cerebral ischemia, then you should consider moya moya as one of the possibility until unless otherwise proved. It generally occurs in the watershed areas, and most of the time precipitating factor, the history given by the parents is the child was crying or there was some sort of exertion, and after that he had this onset of stroke. Dehydration, cold or fever can also precipitate. So they'll present with different forms of stroke. Second thing is hemorrhage because of the saccular aneurysm, as I said. There can be headache. Now what happens? The compensation of formation of the vessel, what we call moya moya vessel, it not only happens inside the cerebral vessel, but sometimes it can happen at the meningeal or leptomeningeal vessel. And whenever the leptomeningeal or meningeal vessel get dilated, they'll irritate the dura and there'll be a headache. Very rarely, whenever there is this moya moya vessel are situated around the basal area, basal ganglia, then there can be a choreiform atherosclerotic movements. The story is a little different in case of adults. Adults, they will generally present with the hemorrhage because of the saccular, either because of the saccular aneurysm or sometimes the moya moya vessels, they are very fragile and they bleed. The bleeding can be either intra or periventricular. The annual bleeding rate, if somebody is diagnosed with the moya moya, the adult will carry an annual bleeding rate of around 7%, and it increases with every bleeding chances. So it carries high morbidity and mortality, and the second most common presentation is ischemic symptoms. The pregnancy actually aggravates the moya moya, increases the risk of the moya moya. So that is as long as the definition, etiology, and the symptoms are concerned. About the diagnosis, we've got various modalities like CT scan, MRI, and MRI, of course, CT angio. The gold standard is digital subtraction angiography. There are newer techniques to see how much is the perfusion pre-operative and post-operative. I'll tell you about that later. So let's come to the CT angio. The plain CT scan will tell you only two things: whether there is a bleed or not, and second thing, whether there is an infarct or not. That's it. Not the thing more than that. Next thing is the MRI. MRI is a good screening tool, and it shows a lot of times this signal voids in the basal ganglia, which are nothing but the moya moya vessels, and whenever they're in the basal ganglia, they will call them choriothetoid movements. What you should see is once you've given the GADO, there'll be this leptomeningeal enhancement, and there is one sign defined to that. I'll tell you about that later. On diffusion weighted, you can see any infarct and hemorrhages in the early stage and in T1, T2 in the later stage. So this is this sign. It's called the IV sign. What happens is, so whenever you give a GADO, there'll be enhancement of this leptomeningeal collaterals. And when you go to the flare sequence, instead of flow voids, on the flare sequence, you will actually see a high signal of those collateral vessels. And that happens because there is very slow flow of the blood in those collateral vessels. Now, somebody must have seen this and he must have recognized about the IV plant. This is the IV plant, sort of decoration plant, and he named it as the IV sign. So that is the IV sign. Sometimes they do ask in the exams for the young neurosurgery residents. Second thing is what you see in the MRA is the stenosis. As you can see, this is the ICA going, the stenosis of the ICA before the bifurcation, and even the A1 is also stenosed. Sometimes you see total occlusion, like this is the lateral view, the ICA is coming and the ACA is completely blind. You see only MCA. And of course, you see moya vessel. What is the gold standard is the DSA. DSA is the gold standard because it provides you a crucial surgical planning data, whether your external circulation is intact or not, and whether you will be able to do the anastomosis or not. So this is the scan. As you can see, this is the moya vessel. This is the ICA. The ICA is totally blocked after the bifurcation, and this is the ECA. So ECA is giving collateral, so you very well know that external circulation, external cerebral artery is intact, and you can actually do a good anastomosis with that. And the added information can be the aneurysm, so whether there are aneurysms or not. Now, these newer techniques of cerebral blood flow study are actually used to see the how good your bypass has worked. So what they do, they will do the this perfusion techniques like xenon, enzyme CT, or PET CT or SPECT CT before the anastomosis and after the anastomosis, just to see how much is the improvement at the level of the perfusion. So that's about as long as the diagnosis is concerned. There is one grading system given by Suzuki and Takaku. It's very beautiful grading system. There are totally 6 grades. In grade 1 and 2 is basically initiation of the moya in the form of first grade is just the narrowing of the carotid fold, and second grade is just the initiation of moya. You may not actually see the moya vessel. In third grade, actually you see the intensification, and towards the 4 it actually started minimizing. Maybe you've achieved anastomosis, or there is a natural anastomosis and it starts minimizing. Grade 5 and 6 is almost reduction and disappearance of the moya. So that is the grading of moya. There is another grading given based on the location. So where is the moya vessels are located? If they are located in the basal ganglia, then the circulation is basically through the lenticulostriate or choroidal. If they are located in the ethmoidal area, then the supply is through the ethmoidal and the ophthalmic artery, and sometimes the vault vessel, that is the dural vessels, are giving the moya vessel. So that's as long as the definition, etiology, the clinical presentation, the diagnosis and the staging is concerned. Now let's go to the management aspect. First of all, as long as the medical management is concerned, there's no definitive medical management. We have certain drugs and they work just as a palliative. So like aspirin can give in those patients who present with a stroke or TIA. Anticoagulants or low molecular weight heparin can also be given. Calcium channel blockers are given for those patients who've got the headache because of the leptomeningeal vessel collateral. And steroid can be given in case of those patients who've got this involuntary movements if the moya is in the basal ganglia. Surgical treatment, the main aim of the surgical treatment is basically to augment the cerebral blood flow and to improve the cerebral hemodynamics. The methods we've got either direct revascularization, indirect revascularization, or combine both. And I'll tell you one by one about that. What is the criteria for the revascularization? Who are the patients who are the candidate for revascularization? Is the one who are basically who are symptomatic patients with a good neurological status. The second is if the infarction is less than 2 centimeters on the CT and all the previous hemorrhages have resolved completely. If it is acute infarction or acute hemorrhage, generally you wait for some time to do it. Angiographic stage of Suzuki grade 2 to 4, that is initiation to the intensification, and timing, that is more than 2 months after the most recent attack. So let's go towards, we'll see the direct bypass techniques first and then the indirect. Professor Bingsu has already told about it. So I'm not going to show you any patient video. I'm just going to run over this. First one is basically an STA-MCA anastomosis. It was basically described by Yasargil and Dohaki in 1967, and initially it was used for adult Moyamoya disease. First, you take a donor vessel with the use of Doppler, and you can have various techniques. Either you can do it from outside inside, or you can do it from inside out, like how Professor Bingsu does it. It reflects the scalp, and then he separates it more, which is more elegant way of doing it. Your craniotomy has to be precise, but where should be your craniotomy? Your craniotomy should be exactly 6 centimeters above the external auditory meatus or the end of Sylvian fissure. So that is where your craniotomy has to be, at least 2.5 to 3 centimeters in diameter. But Professor Bingsu was able to achieve it with 2 centimeters of craniotomy. Now, what are the vessels which are chosen? We choose either the posterior temporal or the posterior parietal. Generally, suture material chosen is 10O, 11O, or 8 to 10 interrupted or continuous suture, depending on the choice of the surgeon you can put. So that is about the STA-MCA anastomosis. Advantage is it's a selective supply. You can actually put the anastomosis depending on the area which has developed the ischemia. Second thing is STA-MCA double barrel anastomosis. So nothing but what you do is, here both the frontal and parietal branches of the superficial temporal artery are anastomosed on the middle cerebral artery. So whenever you're using both the vessels and putting it on the MCA, then it is a double barrel bypass. That's it. In case of the posterior stroke, or when the posterior circulation is affected, you can use occipital artery as one of the alternative. Next thing is what is called direct revasculation with STA-MCA and STA-ACA. Little different as long as the technique is concerned, that you have to do actually a bicoronal skin incision, and you have to do 2 craniotomies separately, one for the STA-ACA anastomosis and one for the STA-MCA anastomosis. So that's it. And what other technique is called as STA-MCA single vessel but double anastomosis, where in case when there is a symptomatic Moyamoya disease with a very poor cerebrovascular reserve, then you can actually do a double anastomosis, where at one place, so this is the STA coming, at one place you make a end to side anastomosis, and at one place you make a end to end anastomosis. So side to side and end to side. So in case of very poor cerebrovascular reserve or the very poor ischemia, then you can actually have this. What is important is to choose your suture material precisely, and so generally what happens when you're using proline or ethylone, you can see the eye of the needle is larger than the suture material, and very rarely sometimes when the diameter of the vessel is very small, or sometimes the vessel is very fragile or very delicate, especially when you're doing it in the very younger age. In that case, the vessel will give up, or whenever you're taking out your needle, you're taking out the eye, there'll be a bigger hole. You can see, so this is the dura. Your eye is going, and after the eye, the suture material is going, and there'll be a hole created there, and those are the potential sites for the leak. So what you can use is, this is the Gore-Tex suture. Gore-Tex suture are nothing but the expandable suture. So suture materials, you can see they are larger than the eye of the needle. So Gore-Tex suture basically used by cerebrovascular and plastic surgeon, and it can actually give a better alternative in case of the challenging cases. So that is about the direct bypass. There are various indirect bypass techniques and very confusing names. I'll just try to clear those names for the young neurosurgeon. So basic idea of indirect bypass is basically mobilizing a vascular tissue supplied by an external carotid artery and placing it in contact with the brain. So that is the basic idea, and you can use different types of vascular tissue. I'll go to that. So the aim is stimulating the revascularization, and the extent of revascularization is unpredictable. So you're just taking some tissue and putting it over and believe that it will work, but it may not work. But it can be a good alternative in case when you're not able to achieve a direct bypass. especially useful in case of pediatric population. And that is just, very beautiful temporal profile, how it has evolved. So can you see, in 1979, there was just encephalomyosynangiosis. In 1980, there's the Omental Transplantation in ET1, encephaloduroarteriosynangiosis. Then I'll go one by one, but this is how it is evolved, and we have come to the pansynangiosis or the encephaloduromyoarteriopericardial. I'll go to that one by one. So first thing is just encephalodurosynangiosis. Very simple. What you do is, once you've got your craniotomy done, so you have to preserve these dural vessels and make a craniotomy along the dural vessel, and you just have to dural leaflet, sweep it under the dura. So this is what you're going to get. So there'll be encephalo, that is the brain, and the inverted dural leaflets, and you've got your bone. So that is encephalodurosynangiosis. So the anastomosis between the brain and the dura. That's it. Next thing is encephalomyosynangiosis, where what you're doing is basically you're connecting a bridge between the muscle and the brain. So once your craniotomy is over, once you've reflected the temporalis, that temporalis actually, of course, you have to put your dural leaflets back, and then this muscle, you have to suture it over the dural edge. So then you call it encephalomyosynangiosis. So what you've got is, you've got your brain, and then you've got your lift of your muscle coming, and which is attached to the dural edges, and hope that there'll be some neovascularization between the brain and the muscle. So that is encephalomyosynangiosis. Next, encephaloduroarteriosynangiosis, where what you're doing is basically you're bringing in the STA. You have actually identified the STA, bringing in the STA and putting it over the raw brain. So what you're actually making it, this is the encephalo, that is the brain, that is the cortical MCA branch, and this is the parietal branch of the STA coming bone flap. So we've got better possibility of neovascularization. You've got the brain, you've got the dura, and you've got the STA also. That is encephaloduroarteriosynangiosis. Next thing is whenever you have the posterior cerebral or the vestibular arteries involved, then you can use occipital artery as one of the alternative instead of the STA. Next is encephaloduroarteriomyosynangiosis. So what you do is, once your bone flap is out, you have to bring in not only the STA and the muscle. So basically, you're going to create anastomosis between the dura, then the STA, that STA to the muscle, and then again muscle to the dura, again muscle to the STA, and again dura. So if you see the cross section, you've got the brain, you've got the muscle, and you've got the parietal STA also. So there are better chances of neovascularization. Next thing is, if you're not able to achieve any of that, then you can actually do an Omental transplantation. But here you'll have to do anastomosis of the gastroepiploic artery and vein to the STA. This is actually useful in those cases when you are not actually able to bring the STA, or STA is very short, or you've broken it and you're not able to bring the STA to any branch of the middle cerebral artery. This can be a better alternative. Other technique is, you can actually do multiple cranial burr holes. It's a very beautiful technique. See, what you're doing here is, once your skull flap is over, you are actually doing this V-shaped cut of the pericranium, reflect the pericranium to a burr hole. After the burr hole, you open the dura, you have to open the arachnoid, and then you have to sort of put the pericranium inside, and hope that the pericranium is vascular tissue. It will create some neovascularization. So that is the multiple burr hole. Sometimes it does work. Sometimes you can use pericranial flap. It is especially useful in case of the anterior territory ischemia or infarct. So what you do is, you make a bicoronal skin incision, but make sure that your pericranium is intact. So you have to infiltrate nicely and raise your scalp above the pericranium. So make a skin incision. After that, pericranium should be raised in the form of two V shapes. So this is one cut, and this is another cut, and reflect it. After that, you're going to put a burr hole right of the over the suprachiasmatic sinus, cut the dural incision base towards the sinus, and after that, you're just going to put your pericranium down there. and hope that the anterior cerebral territory area will have some vascularization through this pericranium. Now, second thing is, of course, you can combine direct and indirect technique, and which is obviously a better choice. Why I'm saying this, that there is one beautiful study done which actually calculated the extent of the relationship between the extent of craniotomy, dural opening, the type of donor tissue you've used, and the surgical collaterals which have developed. So you can see if you've just done encephaloduro-arteriosynostosis, this is your craniotomy, and you use donor tissue as dura and supratemporal artery, and you can see what is the post-operative status of the neovascularization. Compared to that, if you've done a larger craniotomy and you've used a very big muscle, and you can see a very beautiful neovascularization. If you've done encephaloduro-arteriomyosynostosis, where you've used everything, dura, STA, temporal muscle, and you've got beautiful neovascularization. And next thing is what called pansynostosis, where you use whatever possible, that is dura, STA, temporalis, muscle, and pericranium, and you can see the neovascularization. So basically, the more donor tissue you use, and you use combine both direct and indirect, there is more chance of neovascularization. So that will basically benefit the patient. Now, towards the end, perioperative care, the patient in the stable condition without a frequent ischemic stroke. So patient shouldn't have any recent stroke or any recent hemorrhage. There should be adequate hydration, otherwise it will precipitate more ischemic attack. There should be normal PCO2. Should be very well cover up the analgesia, and there should be normal thermic, and the preoperative evaluation of the hemodynamic dysfunction with the acetazolamide, with the caution and surgery performed, because you can actually use this post-operatively to see how beautifully or how good the perfusion has happened post-operatively. About the assessment of revascularization, there are two techniques of assessing. There is one grading system given by Matsushima, who says that grade 1, grade A, B, C. Grade A is when you've got more than 2/3 of the MCA territory is got revascularization. Grade B is fairly about 1/3 to 2/3, and grade C is you've not got anything or very slight. On the contrary to that, the Doppler grading is more convenient and useful. It says there are 3 grades, and grade 1 is you found no new vessel formed. Grade 2 is you're able to see 1 to 4 vessel formed, and grade 3 is you've seen that there are more than 4 vessels are seen on the Doppler. On the follow-up, clinical evaluation and angiography should be done after every 6 months. The angiography, thereafter that angiography should be after 1 year, and the MRA should be done annually from the 2nd year onward. About the prognosis, generally after revascularization, the ischemic component is taken care very nicely. They mostly become free of the ischemia or TIA, but there is always a chance of rebleeding because you've caused a new vascularization. So these new blood vessels which are formed, sometimes they're leaky, and there is always a chance of bleeding, around 30 to 60% chance of leak in the follow-up cases. In case of unilateral moya disease, generally it becomes bilateral in 7 to 27% of the cases. This is just one case I'll show you, which we had performed. Since Professor Pingsu has already shown many cases, I'll just show one case. So this is the parietal branch of MCA. This is the STA which has come, and this is the site of the anastomosis. So this is end to side anastomosis, which we've done, and now we are trying to do the ICG with the endocytic green. So you can see once the dye goes, you have to see not only the parent vessel but the small collaterals which are open. That is what it shows that your anastomosis is worked good. This was one of the first case which I had assisted. The conclusion: moya has a bimodal age distribution and variable irreversible clinical presentation. Hence, early diagnosis, prompt treatment, and regular follow-up is the key in the management of the moya disease. Thank you very much.
Thank you very much for Dr. Sachin for your very wonderful presentation about moya in the adult and pediatric. I believe right now is the discussion session, or maybe Dr. Sachin, do you have any idea? We have one question here from Dr. Danu Rolian. Should we continue to the question and answer right now, Dr. Sachin? Or
yeah, we can continue.
okay, one question from Danu Rolian. Good evening, my name is Danu Rolian from Indonesia. Air Force Hospital, Jakarta. Permission to ask Professor Subin. It's an honor to see technique. I enjoy meticulous technique regarding making suture in bypass. Some surgeons advise to switch to opposite hand in pulling the first knot and subsequently switch back to the right hand to complete the knot. How it of time saving in cementing the best patency bypass suture. Thank you, Professor. I believe you already have answered your question, but maybe you will explain it more, Professor.
Yeah. Thank you. Danu, actually, we are already friends, and if there's no pandemic of the COVID-19, you may be here already. Actually, if it's a moya bypass, normally you can operate on a plane. It's just like a plane. But if it's a deep suturing, like I presented to the first, the radial artery to MCA, it's quite deep and narrow space. If you use two hands to switch, actually it needs more space. Normally, so I only use one hand to make the knot. You can try if you are interested in different techniques, and then you can choose whatever you want, and there's no best techniques. There's only what kind of technique fit to yourself. So that's my opinion, and I just because I mentioned my technique is the most simplified anastomose. Normally, it only take less than 14 minutes for the temporal occlusion time. Now I already presented for my trainees. I have 4 attendings in my team, and they all can finish the anastomose for one stoma less than 20 minutes. So it's quite fast. I think switch the hand. It sounds better, but actually, when you tried, you may find it take more time.
Thank you, Professor Subin. We have another question I can read here from the chat by Christian Beta from Indonesia. He's asking, which are the disadvantages of continuous suture, running suture, so that you choose interrupted sutures? So actually some neurosurgeons prefer running suture, but you use interrupt suture. So which
yes,
is
interrupt continuous suture for like CEA. After the CEA, I also use a continuous suture because the vessel wall is quite thick. But especially in moya vessel, the donor artery and the recipient artery, the thickness of the vessel wall is quite different. Sometimes the donor artery and the thickness of the vessel wall may be 4 times than the recipient artery. So if you use running suture, actually it's very difficult to achieve the even tension between the navel knot. But if you use interrupted suture, it's not a problem. You can make you just control the even space between the different stitches, and you can get the even tension. But if you use a running suture, you can. It's very hard to get the even tension in different stitches. So sometimes it can be, it couldn't be very even. So sometimes maybe maybe cause a leaking of the blood. So actually, when you remove the temporal clips of the donor artery, actually, normally the recipient artery can expand it a lot, especially in the monomer vessels, monomer anastomos. The donor artery, the pressure is quite high. Normally, it's around 60 to 70. But the recipient artery, the pressure is quite low. It's only 10 to 12 to 20 centimeter. So the recipient artery can be enlarged a lot, sometimes even 2 times. So if you use a running suture, it can the vessel wall can be expanded and can cause very severe bleeding.
Thank you.
So that's my suggestion. So that's why I always use interrupted suture.
Thank you.
We have another question here from Dr. Biozardi from Indonesia. Very nice presentation, Professor. I have one question. How long the maximal time to do the bypass from onset? Thank you very much. Please, Professor Subing.
Yeah. You mean the direct bypass in children with monomer disease and the syndrome? So the children depends on the ESA result of the angiogram. Normally, if the patient's age is younger than 7 years old, I always use EDMS, encephalodural myosyringesis. That's enough. Actually, according to the results, we followed the angiogram. Actually, not only the deep temporal artery, the middle meningeal artery, and even the STA can form the stoma, spontaneous stoma, a lot and quite wide. So the effect is almost the same with the STA MCA bypass combined with EDMS. So if the patient is younger than 7 years old, we only do the EDMS. And if you only do the EDMS, actually the procedure time is normally less than 1 hour, and we can perform it very, and the time can save a lot, and that's very important for the pediatric patients.
Nice. And I have a question also to Sachin. Sachin, in your institution, do you have a huge load of moya patients? And second question is, do you use the same technique as Dr. Shubin presented in your institution?
Yeah, so at my institution, we roughly we see more of moya disease in the outpatient department, but since it's a corporate hospital, not every patient which we offer a surgery turn out to be turn into the surgery. So maybe the percentage is whatever patients we've seen in the outpatient department, 50% of them we do the surgery. Roughly on per year, we are doing maybe maximum 7 to 10 anastomosis, and maybe equal number of the EDMS. So that is what, as long as the protocol is concerned, I think we fairly follow the same protocol what Professor Bingsu was saying, that if the child is less than 10 years old, then in that cases we do EDMS. But if you're able to get a good diameter of STA, and if the child is the adult or more than 10 years of old, or at least 60 kg, then I think it's preferable to do the direct anastomosis.
Thank you, Sachin. Someone else want to ask question to our?
I missed some part of the question.
Yeah.
May I know what is the diameter of the donor and the recipient vessel in direct revascularization? So actually, in the molar vessel, the donor artery for the female patients is not normally the diameter of the STA is around 1 millimeter, and for male patients it's normally 1.2 millimeter, and the recipient artery from 0.4 to 1 millimeter. So this kind of range, I think. So if the recipient artery is larger than 0.4 millimeter, we all can do the direct bypass.
Thank you. Maybe we have other questions.
Can I ask one question?
Yes, please, Dr. Liu Bunsang.
Professor Zubin, I want to ask you regarding the side-by-side bypass, especially A3 bypass. I believe that the deeper end, that there's no way we can do interrupted, and most surgeons will do a continuous suture for deeper end. May I know that how do you make sure that the continuous suture on the deeper end, that the suture knot are tying outside the vessel? Do you tie to the initial anchor suture that you have on both ends? And can you tell us about your tricks on doing that? Thank you, Prof.
I beg your pardon?
When we're doing a continuous suturing for A3 bypass for the deeper end, so how do you...
A3,
yes,
okay,
A3.
Side by side.
Yes,
side to side, yes.
Yeah, I believe the deeper end, yes.
Yes, that's the only condition that I use running suture in the back side of the side-to-side anastomosis of the A3 to A3,
So for those continuous suturing, how do you anchor the knot? Tie the suture knot for the continuous suturing. Do you tie to the initial anchor suture? Because I was thinking that how the technique to tie the knot outside.
The same technique described by Kamiyama.
Thank you, Prof.
I think Redab.
Yeah.
Yes, please.
Thank you. Have a good evening, good morning, everybody. It's always a pleasure to have a meeting with you. Professor Benzo, thank you very much for the enlightening lecture. You always give us such informative lecture. Actually, I have two simple questions. One technical question, and another one about the aneurysm. So in aneurysms with Moyamoya disease, what is the best approach to deal with it, to clip protocol before and after you deal surgically with the bypass surgeries? And the simple question about technical issues that running 10-0 sutures, I noticed that it's always transparent one, so it's very difficult to see them by your microscope. So would you ever use a colored one, like one that's not transparent, to make it more visible during surgery under a microscope?
Actually, the 10-0 pruning suture is blue. Yeah. you can see under the microscope. And actually, the trick, the tips to control the suture is you always keep the suture tear in your surgical field. So the surgical field, Dr. Filetti and Dr. Liu, they all visited my department, and the surgical field was covered by gel foam. Only the space we need to create the bypass was exposed. So you only need to take care of the suture tear in the microscope. Actually, the suture itself, the needle itself, you don't need to take care where it is. If you always keep the suture tear in the surgical field, you wouldn't lose it. Yeah.
Okay.
And the another question is about the aneurysm of the moya.
Well, during when you have both an moya and we have aneurysms.
Yeah.
So
there's two conditions for this aneurysm. One is in the Willis circle aneurysm. Sometimes we can do the direct clipping for the Willis circle aneurysm and combined with the revascularization procedure at the same time. But sometimes more frequently, actually the aneurysm is a peripheral aneurysm. Normally it's a very deep. Actually, this kind of aneurysm is pseudoaneurysm because of the bleeding. So this kind of aneurysm normally can be absorbed after 3 months. So maybe 80% of this kind of peripheral aneurysm can be disappeared after 3 months. When you redo the angiogram, it may already spontaneously disappeared. And sometimes if you do the revascularization, it is also helpful to let this disappearing of the aneurysm, peripheral aneurysm. Yeah.
Okay. Thank you so much, Professor. May I have another question for Dr. Session?
Yeah, sure. Tell me, Rita, how are you?
Hi, how are you? Regarding that encephalodural myangiosis, encephalodural synangiosis, when we just pull the dura inside the just above the peri-mater and the cranium will be completely exposed, would you put another layer over the dura which has been folded inside just before we place back the bone flap? Because I expect that direct in contact of the bone flap to the brain will make it irritations, and there will be high risk for seizures and epilepsy or convulsions. So my question, would you put another layer after you just flip back the dura folds?
I think nowadays nobody does only encephaloduro anastomosis. Whenever you're doing encephaloduro anastomosis, nowadays it's always combined with encephaloduro myosynangiosis. So the muscle layer is always there to protect the bare area of the brain from the exposed bone. So I think always just one of the modalities which is described in the literature. So I was trying to say put up that. But it's always better to cover the bare area of the brain with the muscle layer, and then it makes it complete.
Okay. Thank you so much for your lecture. Thank you.
Thank you. I have one question for Professor Bingsu. Actually, two questions. One is, I for no doubt you are excellent neurosurgeon at PAR, and you don't have any space for mistakes. But for the young neurosurgeon, what is your suggestion or teaching? Because I've seen whenever you're doing any anastomosis, that particular area where you making anastomosis, what we've seen other neurosurgeons doing, they will always cover that area with some sort of a material behind, maybe material with the rubber or with some paper, so that the area becomes more visible. Your neat suture material is more visible, and at the same time, you're, mistakenly you're not damaging the brain. But I've seen that you've never putting it. Why do you don't put, or do you recommend your students also to do it that way, or you tell them to put some cover over the brain? One thing. And second question is, now all of us, we know that you run a sort of a training course at your institute for training for the young neurosurgeon to train on the Moya anastomosis technique. How do the people how do we get in touch with that? Or how do the young neurosurgeon can apply? Maybe you can tell us something about your fellowship course for the young neurosurgeon from the ACNS. So these are the
no problem. Actually, we are the ACNS and the WFNS training center, and you can write me an email, and we can arrange for your visiting. And now, actually, because of the pandemic of COVID-19, there's already more than 10 neurosurgeons in this queue.
Okay.
So we can arrange it after the. But now the program was stopped because of the pandemic. Okay. So after we reopen it, we can deal with this visiting scholars things. So we can arrange it for you. Yeah. Okay. And actually, you mean I don't use any rubber mat?
Yes.
Actually, I don't think it's helpful. Before you do the anastomosis, you should have the full confidence that you can control the needles very safely. So if you don't have this kind of confidence, my suggestion is you still need more practicing, and then you can go to practice anastomosis on the patients. So if you can control the needle very safely and very effectively, you don't need this kind of additional things.
Thank you very much.
That can make your procedure more safe, more easier, and you got the more space to do the anastomosis.
Yeah, about this topic, I remember when I visited you that sometimes you also leave between the two temporary clips, there are some small perforators that you leave open, right?
Yes.
You can double check. You can have the blood, right? Tell you if the bypass is working. And I think probably if you use rubber behind, you can damage or interrupt the small meshes. So this can be, in your opinion, another reason why to avoid rubber mat.
Yeah, and actually, you know, in the especially in Moya vessels, this kind of recipient artery always have a lot of small branches. If you coagulate the small branches and put the rubber mat under the vessel, actually maybe you already hurt the intima of the recipient artery. Yeah, and that's very dangerous. And the recipient artery was so fragile that if you put some additional things, you may cause some spasm of the recipient artery, and you can cause the bleeding of the recipient artery. So this kind of bleeding is very annoying and very difficult to get the hemostasis. And if you don't use this rubber mat things, use two curved temporal clips. You can clip all the small branches and the recipient artery. And sometimes, just as Verity mentioned, I sometimes left a small perforator open and let the blood reflux a little bit. So that can make the recipient arteries vessel wall more visible, because normally the recipient vessel wall was so transparent, and with the help of some red blood, you can see it more clearly. And there's some, if there's some small pressure between the recipient vessel wall, it can keep it open, and you can make less chance to stitch to the other side, opposite side of the vessel wall.
Thank you.
That's further tricks. So this topic is only basic tricks. So I didn't demonstrate this trick. Yeah.
Right. This is advanced.
Yeah.
So any other question?
Yeah, I have 2 questions. Thank you, Professor, for that amazing video that we had. Thank you for sharing it. My question is, what would you advise the young neurosurgeon who wants to start doing bypass to practice on? Would you recommend practicing in the cellistic tubes or animal models like the rat model? And I have another question. In your large series and vast experience, what's the most common complication, if at all there was? What was it in your case series?
Actually, moya surgery is very complicated, and the hemodynamic change after the surgery is very complicated, and this is a very big topic. And actually, I have already presented the hemodynamic changes after the surgery. So this question couldn't be answered in a very simple way. So because it depends on the integrity of the MCA network, and if the network is quite intact, you can do the direct bypass, even double bypass, even triple bypass. And but if the integrity of the MCA network was quite poor, you can maybe only do the EDMS. So it depends a lot of things and a lot of conditions. Have the condition of the vessel wall is very different. So for the Suzuki stage 2 to Suzuki stage 6, it's very different. So it couldn't be answered in a very simple question. And for the practice of the anastomos, yes, if you stay in your home and you have a very simple microscope in your room, you can practice suturing the plastic tube. Yes, but normally we train the surgeons in the laboratory with rats. Yeah, because the rats, the vessel is live, and it has some pulse, and you can practice a very similar to the human being. I never practiced it on some chicken wings.
Okay.
Nice. Some more questions from the audience? No more questions? So
I have a number to report to you. There's more than 3,000 audience in the WeChat channel already attend. Yes, now it's 3,053.
So very, very huge numbers.
Yes, yes.
Numbers, I would say.
Yeah.
Thank you also for sharing through WeChat this webinar, Professor Shubin. Very nice from you. So thank you very much. I want to thank Professor Shubin for sharing his knowledge, Sachin for not only giving us a great presentation about Moya bypass, but also for being a great organizer and leader of this ACNS Young Neurosurgeons Committee. thank you to my co-chair, Mirna Sobana. And thank you, Professor Cato, for supporting these efforts. Thank you to all of you who joined this webinar and gave us the opportunity to share these very important tips and tricks by our speakers. So, Sachin, do you want to close this session? He's not.
Yeah.
Sachin, can you hear me?
Yeah, I can hear you.
Yeah. So probably we should close this webinar, right?
Yeah, it started raining here, so my connection is not very good. So it's a time to close probably.
Yeah. Almost 2 hours of webinar.
Yeah.
Yes.
Okay, thank you to all of you and see you next time.
Okay. See you.
Thank you, Professor.
Bye-bye. Bye-bye.
Thank you, Shubin. Thank you.
Thank you, Professor.
Thank you, Professor Cato.
Thank you so much. It was very encouraging.
Thank you.
Thank you.
Well done. Thank
Bye-bye.
you, everybody. Bye.
Thank you, Azmi.
Yeah, thank you,
Azmi.
bro.
Bye.
Happy New Year. Yeah.
Happy
bye-bye.
New Year to you.
Happy
Bye.
New Year. Bye.
Thank you very much.
You all. Happy New Year. Bye.
Thank you, Mirna. Thanks a lot.
Thank you, Sachin. See you next month. Bye.
Thank you. So, Chetil.
Yes, sir.
So you can send me the recording, okay? Because YouTube, you was little late.
Yeah.
So that YouTube live will not have a complete recording. This, whatever you recorded, save it and send me the link, okay?
Sure. Okay, sure.
Yes. Thank you. Thank you very much. Thank you for the support.